there may be the injection, the drug charts for the patient, so you need to look onto them. Okay? So whenever you go inside, do a bit of scanning in the cubicle, what is placed. They normally ask you to have a look in your trolley. The patient is on the way, even when you enter. Okay? So they allow you 5-10 seconds to look onto the trolley. It's good practice to know what you have and what you don't. Okay, when the patient comes for you. Okay, then they ask you, okay, the patient is here. See the patient. Most of the time, the monitor is already attached. If the monitor is not attached, you should attach the monitor, or you should ask that you want your patient to be monitored. Okay, check the pulses and stuff, everything. Okay. You need to, at every point, you need to be talking to the patient, not to the examiner. Okay? And when you're talking to the patient, do not say, I would like to, I would like to, I would like to. Simply do what you want. Okay? If you want to give them any instruction, rather than saying, I would like to listen your chest, simply go and listen. Ask the patient to take deep breath in and out, deep breath in and out. Okay? And again, and again, and again. Rather, you tell that, no, I would like to listen to your chest, no, I would like to feel your chest. Do it, actually. Okay? And in addition to the assessment, if you need anything, if you want to give any fluid, any mask, any cannula, you need to go to the trolley, pick it up, and bring it to the patient.
I didn't understand the labeling.
That will be airway, breathing, circulation, disability, and yeah. So the trolley has a 5 drawers. Okay. Say for example, this is airway, then the second breathing, circulation, and okay, like this. So there will be a trolley.
Instead of I would like to do this and that, can we say I'm going to do this, I'm going to practice your.
Yeah, but you do not need to say every time. Okay. Yeah, you simply give one clear instruction that I want to examine you quickly. Okay, and then you start. Okay. You do not have plenty of time to keep asking the same thing again and again. Okay, does it make sense?
Yes.
Now.
Should we also say like I'm going to examine you? Is that okay with you?
Yeah, that's a part of sympathy and empathy. Okay, now in terms of the ABCDE, I'm going to tell you what are the things where we are going to look for. Okay, for the airway, if the patient is talking to you, it means the patient's airway is patent. But again, think based on the patient's history, presentation, is the airway going to be patent? Will it remain patent? Like if the patient is coming with the inhalational injuries, burns, their airways are at risk. Okay, patient coming with anaphylaxis, their airways are at risk. So you need to act very quickly, inform the ITU, inform the anesthetist, whoever you think is the appropriate person. Okay, and then look on the nostrils, look on the face. Okay, the lips. There may be the lip swelling. I will tell you about the simulation, what they can do. Sometimes you may see the blue light put in there. It means the central cyanosis. Okay, so you may see the blue light reflecting from the patient's mouth. Okay, that means the central cyanosis. The patient is severely hypoxic. So you need to give them the patient high flow oxygen. And when you are dealing with the airway and breathing, do not delay ABG. Okay, so A and B. Okay, ABC. Okay, before you move to C, you should have mentioned doing about doing the ABG, regardless whether the oxygen is normal or not. Okay, now then you move to B. You need to simply explain the patient very briefly that I want to examine your chest quickly. I may feel and listen to your chest as well. Okay, come down to the feet and sit down. Ask the patient to take deep breath in and out. Okay, look at the pattern. Now you can see in this Simman, you can see the breathing movement. The chest wall is moving. Okay. If there is any stridor, you will be able to hear that. If there is any wheeze, you will be able to hear that. Okay. Going back to A, the tongue can be swollen. Okay, you do not need to open the mouth, but you can still touch it. Do not be physical. Okay, touch it if you want to see, or go closer. You will see the tongue is swollen or not. Okay, the airway is patent or not. I will show you what the tongue looks like, or the airway looks like without the swollen tongue and with the swollen tongue. Okay, then breathing, it can be abnormal. The pattern can be abnormal. Unequal chest expansion, that can be simulated very easily. Okay, pneumothorax can be simulated very easily. The sounds can be changed. One lung can be normal, the other can be abnormal, or both can be abnormal as well. Okay, these are the areas where you will hear the respiratory sounds. Okay, mainly along the bases, and there are two speakers in the top in all the Simmons. Okay, so when are you listening? Do not waste your time in the middle or somewhere. Okay, just focus on the pectoral region and just along the bases. The bases will be heard here. Okay, not on the sides and stuff. And the cardiac sound is exactly at the same place where you hear in the normal patients. Okay, talking about the inspection, they sometimes put the stickers or do a bit of makeup on the chest. Okay, they sometimes put a paper with the dots on the chest on the paper. It means that those are the rashes. Okay, so if you see anything, you need to act accordingly immediately without any delays. Okay, if you see any lip swelling, adrenaline. Okay, and oxygen. All right, so it shouldn't be oxygen and adrenaline. And another thing, for any reason, if you are giving oxygen for any reason, it's a good practice that you look into the mouth before you give the oxygen, because when the mouth will be covered, you will not be able to see what is happening there.
So we are giving adrenaline in A or B?
In A. A. Okay. If the airway is at risk, what is at risk? A, isn't it? Yes. Airway. So we are giving.
First, then oxygen.
Yes. Yes. Okay. And then for the C circulation, you can feel in the Simman, you can feel the pulses, both carotids. The right arm is usually meant for the IV fluids and the cannulation stuff in all the Simmans. Okay, I don't know exactly about the GMC if it is very different, but that's a standard formation of the Simman. That's a standard structure of the Simmans for the major companies. Okay. But there is a pulse on the left. You can feel the radial and the brachial pulses. Okay, you will feel soft pads and the pulses are there. You can come across and you can come and have a look on that. Okay, so these are the areas. If you want to come out. Okay, so these are the soft pads where you will see the pulses are present. Okay. And both carotids. Okay, you can feel not in here. Here, okay. In all the Simmons, the pulses are present at that place. Okay, and you can feel the carotid. You can feel the right carotid is stopped. Okay, but the left is present. You can feel the bilateral femoral pulses as well. Okay, you can do that. Yes, where are they present on this bilateral? But make sure that you don't feel both of them together at the same time. Okay? Yeah. Otherwise, you can give the patient stroke. Okay? You should feel it.
I felt
Now you keep missing.
No, I felt sterile.
Could you feel Shashwati? Yeah. Nothing. Did you try?
Yes.
Okay. And the other thing is, did not simply assume or believe that we cannot see. Okay. For all the pulses, wherever you are touching the patient, the computer is recording. Okay. So if you're not feeling the pulse, but you say yes, there is a pulse, it means it can be captured. Okay. You cannot deceive. It is recorded on the computer, whether you actually felt the pulse or you just dramatized. One each, one at a time.
So this side it's like this, and this side
But you can,
Just
yeah,
yeah.
you can feel. Feel all the pulses, dorsal pedis, okay, both femoral, carotids, and radial.
Sorry, I found this dorsal space.
Okay.
It's very
Let's see.
posterior tibial vein.
No, there is. Just check the dorsal
Is there
pedis.
any pulse in the,
Sorry?
is there any pulse around it?
No, not in the antecubital, but the brachial. Brachial is not brachial. Okay.
Radial, brachial, dorsal is connected.
Yeah. So both femorals are also present. Okay. Yeah. Did you ever feel femoral pulse? Okay. Let me show you. So here are the soft pads. Okay. In all the Simmons, you will see this, feel the soft pads here in the groin. Okay. These are the pulses. Hmm?
If we do that, then
No, that's quite obvious. Okay. However, if in case of acute limb ischemia, say for example, you need to establish where exactly the pulse is present. Okay. Say for example, there is no pulse in the right leg. Okay. Then you need to establish where exactly the pulse is.
Yeah.
Okay. There is no popliteal. Okay, now I will show you what the airway problem will look like. Okay, you all should see the difference between normal tongue and the swollen tongue. Okay.
Is there posterior tibial?
No. Okay. So
Thank you.
now this is a trismus. Just have a look into the throat of the patient. Okay, one by one. This is tongue swelling. Just have a look if you can see the airway. Okay, this is a closed airway compromise. This is a situation that you may see in patients with the anaphylaxis, burns and stuff. Okay, just have a look all one by one. Then I will open the airway.
So the tongue looks swollen.
Yeah. Can you see behind the airway? Can you see
No,
that?
no.
Okay. So this is what can be simulated very easily. Okay. Look into the mouth properly. Yeah.
so we cannot see the tonsil.
No.
That's the sign.
Okay. Okay. Now you see the airway is open. Okay. Check the airway quickly. Is it open or no? Yes or no? Can you see the difference?
Some sort
Okay. Shall I do it for every individual, close and open, so that you can see the difference? Okay. So Shashwati, this is open and this is closed. Okay. Closed, open. Can you see the difference? Okay. Hamid, this is open. Okay. And this is closed. Can you see the difference?
Yes.
All right. This is closed, Naga. This is open. Can you see the difference? This is open and this is closed. Is the difference clear?
Yes.
Okay. Closed and open. Anjali,
Oh, okay. One more person before.
okay, so this is open and now closed. Alright, so these are the main things that you need. Tell me, is a close or
It's
open?
closed. Yeah, this open.
Oh.
It's clear.
Okay, is it clear? Okay, and your examiner can tell whether you are actually feeling the pulse or not. When you put the hand there, the monitor, this computer picks it up. There are the sensors with the vessels. Okay, when you touch, it gives the signals to the system. Okay, it will remain in the record, and we can create the report on what you did. Okay, and when you did. So you cannot simply just pretend that you're feeling the pulse. Okay, put your effort to feel the pulse if you're not able to find it. Okay, do not simply say that you have shown the examiner. Okay, you cannot claim.
But in the real exam, there won't be any kind of those sponges there. It will be like normal, the other side.
No.
Yeah, and we have to feed both sides.
Who said that?
Pulses. No, I'm asking.
No, this is what I said. There will be the sponges. There will be the soft pads. Yeah.
Okay.
So there's a standard structure of a simmer.
So we
Okay.
don't have to check the other side.
You can simply
Demonstrate some.
pretend, and you can say the examiner, I assume there is a pulse, or
Yeah.
you can mention that there is no pulse, I cannot feel any pulse on the right hand. They will say, okay, assume. Because this right arm is meant to be used for the IV cannulations and stuff like that. Okay?
Ideally, we have to do it on both sides, right? Like
But yes, you still need to do on both sides. Do not simply assume that because there is no pulse and you're not going to feel it. Okay?
Because in limb ischemia, we have to, the pulses will be feeble on the other side, whichever.
For the limb ischemia, the pulse has to be absent, okay, not feeble. Okay. If it is feeble, that's a chronic limb ischemia, not the acute one. Okay. So for the acute, there has to be no pulse. Okay. Now about what you need to do, and for the airway, these are the different airways and the mask and stuff. Okay. What is this? Riyam?
No,
non-breathable.
Riyam, what is this?
Non-rebreather mask.
Okay. Hamdi, tell me what is this?
Nebulizer.
Huh?
Nebulizer.
Okay, nebulizer. Okay, very good. And what is this?
It's a nasal cannula.
This is a nasal cannula. Okay. And did anyone see those kind of structures? What is this?
Venturi mask.
This is a venturi. This is a venturi, okay? This is a venturi. So it has holes on the sides, okay? And this goes into the mask. You may get a fully assembled mask. There may be fully assembled mask, or you may need to choose any of them, okay? There are different colors, and they tell you how much percent or what percent of oxygen they will deliver, okay? Pink, red, green, white, and blue. Okay, so they deliver different amount of oxygen. How you will determine what you need based on the ABG. Okay, based on the ABG. Does it make sense? Okay, you can just have a look. This is a 4 liter, 28%. Okay, I normally suggest you to smokers to give to the smokers this one. Yeah, easy to remember, white cigarette and white venturi. Okay, so yes, this will deliver 4 liters of oxygen. Okay, but you can choose any of them. Okay, and mention that I will do the ABG, and if we need to optimize, we'll do that accordingly. Okay.
40% oxygen.
This is a 4 liters and 28%. Okay, 4 liter per minute. You can read it. Okay, this is 2 liters.
So if that is a smoker's cough, COPD case, then and the ABG results are not out, we don't know. Is there any standard?
For that you can start with I would say start with the white. Okay. Another thing is for you to just create an idea and the imagination for you to memorize things. Okay.
Do you have to memorize this white?
No, if you want to, yeah, this is for the smoker, keep the fine. Okay. And we know that if someone is getting more oxygen, they look pink and red. Okay, so this is 40%. This is 15 liter, green, everything green. Okay, so oxygen from the trees, yeah, that's green. Alright, so this one is slightly less than that. Okay, they're 15 liter. This is 13 liter. Okay, and this is slightly less. Okay, red and white and blue. When the oxygen is even less, the patient turns blue. Okay, the more hypoxic, cyanosed. Okay, so but better you choose any of them or white. Okay. So if it is not assembled, you need to assemble it for you so that you can use it. Okay. It simply goes into this end. So you need to assemble and connect. Okay. Is it clear so far?
Yes.
Okay. So if you're saying that you want to give the patient, if your patient has COPD, then choose this. Okay. If your patient does not have any COPD or you do not know the status, choose this. Okay. If the patient is on home oxygen, then you should choose this. This will give a continuous regular supply through the nasal cannula. And another reason is if the patient has nausea, vomiting, okay, then nasal cannula, okay. Then choose the nasal cannula. Do not give them the mask. They may vomit, they may aspirate. Okay. Okay. Now that
Nasal cannula, how much oxygen do we?
it delivers up to 4 liters. Yeah. Okay. and they don't make it very tough. It's very easy, honestly. The only thing that you need to do is just follow ABCDE, stick to your scheme, ABCDE, ABCDE. That is a lifeline. Okay. Now, in C, check the capillary fill time. Start from here, okay. Then the pulse and the temperature and the blood pressure. Okay.
After that, I removed it was don't
Check here, check on the fingertips.
Silences.
Yeah, but here you can check on the pulp, yeah, but it is no standard. It is not very significant by year, but people are still using it. You can check on the pulp, or
So now where we have to do on the main bed.
yeah,
On the side you mentioned
which one is the radial pulse then?
the radial pulse. Yeah, here.
So here.
Yeah.
No, we don't want to be the radial pulse.
Sorry.
So that will be the radial pulse.
Yes,
So
that
we
is a
want
radial
that
pulse.
And then this is the capillary.
Yeah, this is a capillary fill time. Okay. Yeah, check on here.
nail.
Yeah, yeah. Check on here. Okay. No need to check the carotid pulses, okay? Unless you are much worried about the patient is not breathing, you want to start the CPR, but don't do that with the CPR. Okay? If you want to give any fluids, you need to tell exactly the amount, route, and the time, the duration. Okay? If you want to give them any cannula, it will not be considered done until you do it. Okay, so you do not have to actually perform, but you need to fake it. Okay, there will be a strap like this. Okay, you can slide underneath, or you can simply put by the side of the patient on both sides. Okay, so if you put on both sides, that means you put two cameras. Okay, if you put one side, it will be one camera. It will be considered done. Okay, but if you simply say no, I would like to put the IV cannula, but you don't do it, it means that you have not done. Okay. Now, if you want to give the fluids, you need to actually go and pick and choose. You will be marked for, you will be looked for what you're choosing. Okay. So you need to bring it. If there's a stand, then you just hang it there. If there is no stand, you put it by the side of the patient. Okay? It means you've done it. And you need to tell what exactly you want, how much, and over what time to get the response. If you put it there, simply saying that I'm giving normal saline, okay, your patient may not improve until you say, I'm giving you 500 or 1 liter of normal saline over 15 minutes or 10 minutes or 5 minutes. Okay? So if your patient is in shock, just give over 15 minutes. Okay?
So if it's in shock that we are starting with 500.
Yeah, so it's a 250 mils boluses or 500 boluses.
In
Okay?
15 minutes.
No, that's a stat. Bolus is stat. Okay? Push. Okay. Otherwise, if your patient is dehydrated, then you can give over 15 minutes. Like if the patient is coming with a severe sepsis, you can give him 15 to 20 minutes. Okay. What's the management for DK? We give him half an hour dehydrated patient in the DKA. The first bag.
1 liter fast.
Yeah. So 1 liter in half an hour. So 500 mils in 15 minutes.
So for a person to get to be in a shock, blood pressure should be below the 90/60.
We'll come to that. Yeah. Okay. Are we done with this? So if you want to take any blood sample, mention that there. When you're putting the cannula, mention that I'm putting the cannulas and I will take your blood samples. You're telling the patient no to the supplement. Do not tell you wish what you want to do that. No, I would like to do that. I would like to do that. Okay. So you guys waste a lot of time in saying what you would like to do. Okay. So it is not the matter of what you would like to do it actually. Okay, no one wants to know about that. Okay? So because this will not benefit the patient, so you are there to treat the patients. If you want to treat, do it. Okay? So you should be at every single time. You should be talking to the patient only, unless there is something that you want and there is it's not there. Okay. Now going to D. In D, you need to check the people in the D drawer or the disability drawer. You'll find the glucometer, and there will be pentones. Okay. So you need to show this. Tell the patient, I'm going to show you bright light, okay, and just show that. If there is any abnormality, your examiner will tell you. Okay, and for the glucose. You are very less likely to get any feedback on the glucose until you go to. Okay, so if you say that I want to know my patient's glucose, there will be no response. But if you take that, okay, proceed towards doing it, okay, and then you will get the response. Does it make sense?
Yes.
Okay. We're done with this. Now, when you are in the cubicle, you need to do assessment in two different places. One on the patient, second on the monitor. Okay? So it is very important. Now going to the definition, A and B are looked into together. Okay? So whenever you're seeing any patient, so you need to make sure that you do not see only one single parameter. A and B is always together. Okay, so you need to see pulse, respiratory rate with oxygen saturation. You shouldn't be happy just by looking on one single parameter. Okay, so the patient may be 99% with this 22 pulse rate. This is not good, isn't it? So 99% or 98% with the 22 or 32, because it means the patient is breathing very fast. He should be ideally about 15, 16 normal resting respiratory rate. Okay, so this is not good. And the more this goes up, the worse the patient situation is. Okay, if, say for example, this remains 99%, and the respiratory rate goes up to 40. It means the patient is working very hard. Okay, he has to breathe about 30%, 30 times or 40 times to maintain that oxygen saturation. Okay, so we need to start this patient. This is a pre-arrest. Okay, pre or peri-arrest if the patient deteriorates. So always see them together. Okay. And when you're checking this circulation in C, did you ask about the shock, the blood pressure? Someone asked.
He asked. I asked him.
Okay, so in shock again, always check the blood pressure and the pulse together. Okay, the patient with the 92 systolic and 70 pulse is more stable than the patient with 102 and 110 pulse. Okay, so always see them together. Okay, so now after all this discussion, we came to the conclusion that on the patient we need to do five steps A, B, C, D, E. On here we have to do A, B, and C. So the monitor can tell us about A, B, and C. What is happening with A? What is happening with B? What is happening with C? Okay. So when you want to reassess the patient, you do not need to do everything on the patient. Okay. If your oxygen saturation is improving there, it means that your intervention is working fine. So after you complete, say for example, B, and you want to move to C, before you go there, Okay, you can talk to the patient and come and see whether the oxygen saturation is still stable or improving or not. Does it make sense? Any question? Guys,
Yes, I
is
have
it
a
clear?
question.
Yeah?
When you check the airway,
Uh,
the respiratory rate is very high, like 20 something, and oxygen saturation is 97 or 98.
mhm.
Do we need to do anything about that?
When you are reassessing the patient, uh, if the oxygen saturation is maintained,
Yeah,
okay, the respiratory rate
it's
is
high.
it is high, but it is not higher than what you had before.
Yeah.
Okay, then you don't need to do very much about this.
Okay.
Okay, but if it is higher than what it was before when you started the patient on oxygen, okay, then you need to reassess. Okay.
Yeah. So what about if it's at the initial assessment, first time you're checking,
Mhm.
saturation is normal,
Okay.
but respiratory rate is high?
Okay. So it means problem is
Yeah.
with the breathing.
Yeah.
Okay. So what can be the problem that can cause tachypnea?
Yeah, maybe it has a congestion in the chest, for example.
Yeah, pulmonary embolism.
Yeah.
Okay. It can be
Medications.
it can be because of medication, fever, or like pneumonia, or fluid overload, pulmonary edema, like those kind of things. Okay. If it remains there, okay. Say for example, the oxygen saturation was 98%, and the respiratory rate was 34. Okay. On your reassessment, it is oxygen saturation is still the same, and respiratory rate is better, okay, or the same, then you don't need to worry about it. But if it has gone from 38 up to 46, it means there may be something else. Reassess the patient, listen the patient again, okay, examine the chest again. Okay, it means there may be something that you are missing. And now, after the reassessment, there can be one of the two situations. Whether you don't find anything, if you don't find anything, it means that you just move forward, allow some more time, and come back. But you do not simply stop there. Okay? But if you find any problem, then you treat that problem. Do not move forward.
So for patients that don't have COPD,
Yeah.
what is the minimum oxygen level we want? Like for example,
88.
88 without COPD.
No.
With
Normal
COPD.
patients, normal people without
Okay.
COPD.
Okay. So what's the normal range?
94 to 94 to 90.
Yeah, 94 to 90.
Okay, so for hypoglycemia patients that in the simulation that we did, the saturation was 93 like that. Do I need to give oxygen?
Oh, yes.
Oh, okay.
Yes. Okay.
This
I was coming to this question.
Okay.
Now I see loads of the candidates, they are struggling. They struggling with the answer to the question in what situation we should give oxygen and what situation we should not. Okay. I generally say any unwell patient, give the oxygen. Any unwell patient, give them oxygen regardless whether they are normal or abnormal. Okay, because you will still be doing the oxygen saturation, checking the ABGs, and you should mention that. I will take it off if you don't need. Okay. Hypoxia, if you see hypoxia is primarily the reason of all the tissue damages at different levels. In airway, direct hypoxia, and we know that hypoxia for 60 seconds causes irreversible brain damage. Okay, the patient may die in 20 days or maybe in 3 months after going into the coma, but the neurons which are dead, they are dead. Okay, even if you improve the oxygen saturation.
Regardless, we will give oxygen.
Yeah.
on-
Okay. In breathing, chest trauma, anything, the underlying problem which is going to cause an irreversible damage is the reversible problem, is the hypoxia. Okay. In circulation, circulatory collapse, okay, severe sepsis, anything, okay, that's a hypoxia at the level of the tissues, okay, that eventually starts multiple dysfunctions and multi-organ failure and stuff, and the patient dies from that, okay, from hypoxia because there is a low circulation of the oxygen, okay. In D again, disability, hypoglycemia in the patient develop seizure, okay, severe brain damage, and can die. Similarly, high pressure, okay, patient can die. They have high intracranial pressure. Okay, so oxygen is the main thing at different levels that causes the damage. So I would say start the oxygen. Okay, even in pain, we know even if the pain is in the foot, in the ankle, in the knee, wherever, there's breath holding is a reflex response to the pain. Okay. So why the patient would breathe so fast if they are in pain? Because it's a reflex response. The pain is one of the commonest cause of the secondary hypoxia. Okay, even if the pain is anywhere, okay, they normally tend to hold their breath. Okay, if there is a pain in the knee, so the patient usually they will stop breathing just suddenly. Okay, then catch the breath afterwards. That can lead to again hypoxia. Oxygen is a primary thing.
Okay.
Okay.
I have a question.
Oh yes, I know you have.
Because in same again, I'm talking about hypoglycemia patients that is not so conscious in the beginning. You know, when we come in, we talk to the patients, no response. We look at the oxygen is a bit low, maybe 93-94%. Usually, we should ask if there is COPD or anything of such.
Yeah.
But patient is not responding. What should we assume?
So yeah, assume that it's
No
not
COPD.
COPD. It's not
Okay.
COPD.
Okay.
Okay.
Yeah.
If you can get the response, it's
Good.
good. If you know, good. If you don't, then it means you assume the patient's sick. The patient needs oxygen.
Okay.
Yeah.
So which mask we use for that?
Just non-breathing.
Non-breathing.
Yeah. So if you are assuming that the patient is normal, okay, normal subject, non-COPD, then we are using the same stuff. Okay.
So for circulation, do we always go to cannulas or?
It is good practice. Okay. It is recommended by the NICE guidelines. It is recommended by resuscitation council. Okay. It is always good practice because one you can use to take the blood samples and give the fluids. The other one that you can give the antibiotics and other drugs and stuff. Okay. So it is always good practice.
Yeah, but in heart failure, you're not going to give the fluid.
So what?
So still we are going to.
Yeah. What if the cannula is tissue? It does not take for you. It
Just
does not take. Well, just pick two
Yeah,
of them.
that's okay. But
Okay.
are we going to do anything with the other cannula? It shouldn't be like unnecessarily we are pricking
No,
patient,
no,
nothing
no,
like that.
no.
So do we have to pick up the color or the gauge, or then we just have to see?
If there is any, if you have the multiple options, then go for the bitter size. Okay, like the pink,
Right.
green, gray, red. Okay, any of them. If you do not have the option, then whatever is available.
Do we have to verbalize it while picking up this one?
No, no, you don't. You need to talk to the patient. Okay, so Mr. Smith, I'm going to put the cannula, okay, and do that. All right. Okay, so you need to.
You can pick anyone among the whiteboard, or is there any specification? Like, you
No. Choose any of them. Okay. Better you choose minimum pink, okay, or you can go for the higher, okay, like the gray and the green, yeah, for the red one.
I've seen some people that went for the exam, and the examiner asked them, "What size of cannula do you want to put for the PPH patients?"
So what size
You're
you're
asking
going to use?
white, the most white
Yeah,
board.
white board cannula.
Yeah, the white board
Green or
cannula.
red?
Hmm?
Green?
Green, red, gray.
Green,
Gray.
yeah,
Okay. So
16.
yeah, 16, minimum 18.
okay. Yeah, 18 is a minimum. So yellows are 24, okay, blues are 22, and pink
Yeah,
is
minimum 18.
pink is 20, okay. Then I think
Red is,
sorry,
red is the highest.
gray is
Gray is the highest.
gray is the highest.
No, tell them white board cannula. And ask you what size. Obviously, it's 18.
So So you simply mention that whiteboard. Okay. Anything else? Any question, guys? Rian or Hamdi? Any questions? Hello, Dr. Sadaf, are we connected?
We are
Hello?
good.
Yeah, we can hear
Yes,
you.
yes,
Okay.
yes. Can you please tell the type of granulas and the colors again?
You do not need to worry about the colors. However, there are different colors. You need to mention that whiteboard cannula if you want to choose. If there are the options, then choose any of gray, red, or green. Okay,
Okay, okay, okay.
all of them are acceptable. Okay. Now, in terms of the setting, how the things will be set or may be set, they keep the fluids there. Okay, but they will be blood as well. Okay. This blood will be hidden somewhere. Okay, it is not just visible, okay, and accessible, and that's a common sense. It normally should be in the blood bank, isn't it?
Yes.
Yeah, it shouldn't be just in the toilet. All right. In terms of the fluids, there will be different strengths of fluids, and you will be looked for. You need to find out what you need to give. Okay. Even if you put the cannula, you may be shocked by your examiner by saying that the cannula is not working. No, you have to choose something else where they want to see whether you have any other option, especially in hypoglycemia patients. Okay, um, there there is 10%, 20%, but they want to see whether you can think of giving the patient glucagon or not. Then your examiner may say the cannula is not working, doctor. Okay. Then, then you go and look for the medications. They will be the injections like this. Okay. They are all empty, most of them. Okay, but they have the stickers. Okay. You need to choose, and the examiner may ask you, show me what you have given. Okay. So you cannot simply pretend. Oh, this is simple. If you cannot find anything, then you use this. And any injection, okay, which is not where you use this. Okay, so you need to actually read the name. Okay.
When we have to do the blood sugar, do we have to do the GCS and tell the examiner the GCS at that time?
No, no, you simply stay connected to the patient. No need to just think that the examiner is not there.
So we have to do the GCS after taking the blood sugar or
No, actually the GCS, if you want to do, it comes before the blood sugar.
so do we have to do that or
So no, no. Okay. So if it comes as GCS, that's a different scenario where they simply say the patient is unconscious with the GCS. Okay.
so we have to give dextrose first, then glucagon or first glucagon then dextrose?
It depends. It depends. It is not mandatory. Okay. So glucagon is given only if there is no IV line. Okay. It is not mandatory. If the patient has IV line, then you give the dextrose. Okay.
Okay, in my exam, I gave dextrose
Louder.
first.
I gave dextrose first
Mm-hmm.
and I gave dextrose again
Mm-hmm.
and still the patient was not gaining
Yeah.
that consciousness.
Mm-hmm.
Then I told that I'm going to give glucagon.
Mm-hmm.
After that, the patient started working.
Okay.
Did you put cannula before giving dextrose?
Yes.
Because if you don't put cannula, you will not.
So what I have heard that in hypoglycemia, we immediately, once the patient is not responding,
Mm-hmm.
we will offer like, since the patient is not responding, I will pick the glucometer and will do do myself the BSR. As soon as see the BSR is low, I will give the IM glucagon before going with the IV. So IM glucagon would be done before.
It is not mandatory.
And are we checking the glucose every time we are giving the treatment, like glucagon, then we are checking?
What's the protocol?
It's after 15 minutes.
After 15 minutes. Okay. So we need to ideally check after every 15 minutes.
So but yeah, we would not have that much time on the exam. So do we have to verbalize it? I'll check it after 15 minutes. Then I'll give you dextro, IV dextrose like that.
Yeah. So you should mention that ideally I will check your glucose every 15 minutes until it reaches 4 or above. Okay. Your examiner may ask you what's the reason or what will you do if the patient's glucose does not improve. Then you can choose. You can mention I will give IM glucagon as well. Okay. And I will also check the glucometer, check the sugar again with a different machine. Okay, there may be some problem with that, or the drug may be expired, or not working.
So why do you have to check the name, the expiry date, and then give it?
Yes. So examiner normally asks, you give 1 bolus, 2 bolus, 3 bolus, there is no improvement. The examiner says, okay, what could be the reason? So in that case, if it is not improving, it means the patient may be severely dehydrated as well. Okay. Yeah. And
In hypoglycemia, we have to give fluids as well.
that's a fluid, isn't it?
No, I'm
That's a
saying
fluid.
that's it, not.
Yeah, this is the fluid, isn't it? So we give it.
But when we are giving dextrose, it's mean fluid. 100 ml,
Yeah.
80%.
Yes. But this is, if the patient is severely dehydrated, okay, so it will take a long time for the distribution, the fluid redistribution. You're giving it, but it will take some time to reach. And you're checking the glucose from the fingertip only. Okay. So it may take some time.
So we'll have to proceed with the E and then let the patient report by himself.
Yes. You complete your assessment, come back and reassess it. Okay? Anything?
So in the GCS, you said we don't have to perform the GCS.
Mm.
You just say, I'll do the GCS, then just leave it.
No, you do not
Say it.
say. You talk to the patient.
Yeah.
Okay?
I'm doing GCS for you.
No. Well, your patient know what is a GCS. Talk to
I'm
him,
checking
okay?
for your
So
response.
talk to him. Hello, Mr. Smith. The patient says, yes, it means the patient is A on ABPU scale, okay? V on ABPU scale, or P on ABPU scale. But if there is no response, then you mention that my patient is unconscious. I will proceed towards, I will check the pupils, okay? Check the pupil, and then respond if there is any problem with the pupil, like if the pupils are dilated, fixed dilated, check the pulses again, make sure the patient is dead or not, okay, or alive or not. If they are pinpoint, then the patient may be opioid overdose, okay, so you need to act accordingly. Does it make sense? What next?
E.
In E, we simply tell the patient that I want to now examine you from head to toe, okay? I need to expose you, and then you look for that. Okay? And then you cover it quickly. Now, there are few other confusion that exists among the PLAB 2 candidates. Okay? In the PPH, what do we do? When do we examine? When do we see the patient? Okay? Means whether the patient is bleeding or not. Okay.
We examine the brushing side, abdomen, and bladder, pelvic, and then we check the catheter side, and if there is any catheter.
Okay. When will you check the catheter?
In E.
Okay. When will you check, perform the PB examination, or just check the vagina?
So we will do it after C. When we see that the patient pulse or blood pressure is quite low, then we will do immediately we will move on with the examination of genitals and
Yes. Okay. So you need to examine the patients from the front passage. Okay. If the patient has bleeding, if the patient is in shock, now say for example the postpartum hemorrhage within 24 hours, bleeding within 24 hours, that is a definition, isn't it, of the PPI.
In exposure, do we have to do examination of every system? I mean,
In exposure, no. Exposure is only for the skin, ulcers, rashes, cellulitis, any line coming out or going in.
and then missing examination.
Yeah. Why would you miss?
Like normally we are checking respiratory examination in B and cardiovascular in C, and so sometimes maybe we can miss the abdominal examination, so we are checking.
No, in C, abdomen is not the part of your A to E. Okay, first of all, yes, we do the abdominal examination to feel the aorta. Okay, if the patient is in shock and you do not find any reason, any other explanation, it is important that you feel the abdomen. Okay, you feel the abdomen
Just
too.
after cardiovascular examination.
Not after, as a part of the.
As a part of
Okay.
C.
Yeah, as a part of the C. Okay. Now, if there is any problem with the breathing, like if the patient is breathing very slowly, like respiratory rate is 7 or 8, okay, you're allowed to look into the pupil straight away. Okay, you are allowed to, and you should actually look into before the C. Okay, then you are examining the patient or the pupil as a part of B. Okay, what is causing the trouble?
Opioid question would be
Yeah. Okay.
Actually, we are supposed to do D.
Otherwise, it is a D. It's a part of D. Okay. Here you want to create and get more evidence of your suspicion. Okay. So if the patient is breathing very slowly, okay, bradypnea, then you can examine the pupil as a part of B. Okay.
Volume low.
If, for example, if
Okay. Does it make sense?
in case of hypoglycemia, if we give oxygen, when we assess the airway and breathing, and the saturation does not improve, then
Hypoglycemia, you give oxygen.
yeah, and the saturation still doesn't improve. For example,
Okay. What was the saturation in the beginning?
let's say it was 90,
90. Okay.
then we gave the oxygen, but it
Okay.
doesn't improve.
Okay.
Then do we have to do the respiratory exam at that?
Yes. Yes. When you do the reassessment,
Then we check
okay, then you check. Okay. It may be two different problems. Okay. It may be hypoglycemia as well as airway obstruction. Okay.
In my exam, when it was hypoglycemia, what you said was fine.
Yeah, most times.
Yes. But we are talking about the worst situation, in the worst case scenario.
But if there are some crepitations or something like that, then we have to change it to a different mask.
Yes, then it depends on your findings, isn't it? So whatever you find, you act accordingly.
At that point, rather than focus on the bigger picture, hypoglycemia, we have to fix that issue there.
Yeah, because breathing can kill the patient before the hypoglycemia. And I believe that if he had reached to that point that you found the hypoglycemia, you will treat the hypoglycemia, and this is something that you're finding subsequently before you wanted to move to E, isn't it? So you have started the treatment already for the hypoglycemia, and now you're stuck with the breathing. Okay, and breathing may need ITU, parasitis, and everything. Okay, and this is something that can kill the patient before the hypoglycemia kills the patient.
So basically treat what you see.
Based on the ABCD.
Yes.
Okay, if there are two problems, okay, if the patient has an airway at risk and is hypoglycemic as well, or airway at risk and septic, so you secure the airway and the sepsis. So that should be the order.
So when patient comes with hypoglycemia, patient is not conscious. So we will be starting immediately with the AV score. Like
Okay.
we will-
Yes, this is very good question actually. You may see the patients who are unconscious. Again, what can kill the patient? If the patient is what is the area that deals with the consciousness? D or A? Or B or C? D, isn't it? So we have already talked about the criticality of the situation, the speed that any deterioration can kill the patient with. Airway is most likely the problem that can kill the patient before the unconsciousness. Okay, so we need to still make sure the patient, if the patient is breathing, okay, and when the patient is attached to the monitor, and you can see the oxygen saturation 98%. Okay, I'm happy with that. Okay, move forward. Simply start the oxygen if needed, or you should at least mention at the moment my patient's oxygen is normal and I'm happy. I will keep an eye. That's all. Okay, you do not need to necessarily start it, but you need to reflect what you think. Okay. But do not keep talking to the patient and do not keep telling your examiner as well. You can do the self-talk kind of thing. Okay. So if, say for example, this is unconscious patient. Okay. I want to talk to him. I will come and see. Just try to get the response. Hi Joseph. Hello. So no response. I will just look on the monitor. Is the oxygen saturation okay? I can see oxygen saturation and respirate. I will again focus slightly, look into the mouth, okay, and reflect that oxygen saturation seems okay. I'm talking to myself, okay? I'm talking to myself. Okay? So oxygen saturation looks okay and respirate is also good. Alright, so let's feel the capillary fill time, the pulse. Now I know that, okay? It will take just a few seconds and then I can see the blood pressure and the pulse, that everything seems okay. Check the characters as well. And then you can go straight for the D, disability. Give the pain, shout their names, okay? Uh, pain, no response, look into the people, okay?
Okay. I got
But
it.
you do not need to simply start looking into the pupil. Okay? Again, before you go to D in unconscious patient, you need to reflect that you have assessed airway in the breathing and the circulation. Does it make sense? No?
No,
No?
no. You said you have to reflect. Like
Yeah.
you. So that means you have to verbalize.
No, you can show. You can verbalize, you can self-talk, or you can show by your actions. Okay, you can say, okay, airway looks clear, oxygen saturation is okay, respiratory rate is okay. Quickly listen to the chest. I'm not at the moment. I'm not worried about the unconsciousness because I know the oxygen saturation is okay, and patient is breathing. Then I can see the pulse. Then the next thing that I want to do is look into the pupil. Okay, but what I will not do is that I saw the unconscious patient. Everything is there. I ignore that. Okay, and all of a sudden I discover that my oxygen saturation is 79%. Okay, I don't want to do it. Does it make sense? All right. So, any question? So again, you do not need to see the catheter, diagnose urosepsis. Okay, we see many patients with the urosepsis without the catheter. Okay, so do not be conditional. Do not condition your brain towards seeing the blood hanging, the bag hanging with the patient, to just give you the thoughts of anaphylaxis. Okay, it can be to anything. Anaphylaxis can be to to antibiotics, to maybe to NSAIDs, to the catheter, to anything. Okay. What you need to do is look into the story, what happened, how quickly it happened, what are the signs and symptoms. Okay, and the first thing that you need to do is give them adrenaline, then the oxygen. Okay.
So before that, we
We are
need to
not
stop.
stopping the blood.
Yes, yes. If there is a blood or anything, remove the trigger. Yeah, remove the trigger first.
Without even knowing which one is triggered.
Yeah.
And
Yeah.
what do we justify like for stopping? Should we say like because I'm going to do A to E assessment, I'm going to stop everything what you're receiving, or
No, justification is very, very clear. Patient is unwell, you don't know.
Or we
You
can,
can say,
maybe we can say on my initial assessment, I can
Suspect.
I can suspect that this blood could be a trigger. So I'm just
okay, how many times we need? How many times we need to assess a patient before we get an idea? Okay, out of 100 times, about 80 to 85 times we know what is happening just by listening the story. Okay, just by listening the story. If the patient is coming with a chest pain, 60 years old, was running upstairs, I know this is more likely MI. Okay. I do not need to get the troponin and everything to just to start thinking about it. This is what I talked about in the beginning, that we work on our suspicion and we work in the anticipations. Okay, whatever you suspect, treat it. Okay, and this is what you tell Joshua's mom every time. If you suspect, give the EpiPen. You do not need to confirm it. Okay? Isn't it what you say?
Yes.
Well, this is what you say to the mom. The same applies in your case. Okay? You do not need to wait for anything. Okay? Just read the story. The scenarios are so obvious, honestly. Okay? The scenarios tell you an entire story what is happening inside. You may make mess after you go inside. Okay? But the scenarios tell you what is likely you should be expecting. Okay? So give adrenaline, oxygen, and depending upon the patient's symptoms, the patient may need chlorpheniramine, the patient may need salbutamol, they may need steroid. Anyhow, before we used to give the adrenaline and the steroid and chlorpheniramine, everything. Now the steroids are not included as a part of the protocol. Okay, they can be given only in very resistance case, but not normally recommended. Okay, it,
But when we are giving the chlorpheniramine with the adrenaline or in C,
why in C? What is the role of chlorpheniramine?
chlorpheniramine if there is any allergy. So when we are checking the patient, then we will get to know that if the patient has got any allergy, like respiratory examination.
Oh,
Otherwise, we won't know if this patient.
no, this chlorpheniramine is an antihistamine. It is mainly for the symptomatic relief. Okay, if the patient is itching or stuff like that, then you can give it.
If the patient
Okay.
say, then we can give it. But if the patient
Otherwise,
doesn't
it's
say,
not required.
but if the patient doesn't say,
If there is any rash, just give it. What's the harm in giving it?
so to see the rash, we have to reach to the B.
To be?
Yes, because we are going to.
Well, you can do after E even when you
So,
expose.
so she is asking like, we give adrenaline, immediately we see that the patient is having anaphylaxis.
Yes.
Yeah.
So we are not going to give chlorpheniramine.
No, that's
immediately.
no.
She says, yeah,
That
this
is
is what she does.
chlorpheniramine is a symptomatic drug. It is not the life-saving.
Yes.
Okay. So talking about the life-saving medication, you will pass if you give the patient adrenaline, but you may fail if you just give chlorpheniramine.
And we have to mention the dose of the adrenaline as well.
Hmm?
We have to
Yes.
mention the dose.
So you need to know the doses of the medications on your fingertip. Okay.
So,
Yes.
what did you mean by when you fail, then you give chlorpheniramine?
If you give only chlorpheniramine, okay.
Okay. Oh, that fail.
Yeah.
Okay.
I thought
because you miss a life-saving medication. You need to give it, okay, on time, immediately. Okay, it's a very quick, very volatile, and the effect may go very quickly. Okay, uh, it's not going to harm. Okay.
My question is, when I'm giving the clotrimazole.
Yeah, this is my answer was give any time.
Okay.
Okay, do not care about that. That was my answer.
Okay.
Even if you miss, I said you will pass.
Okay.
Okay, this is not the mandatory drug. Focus on the mandatory drugs. Okay, focus on that. You can give after E. This is what I said. Even after the exposure, you found that there are fading rashes. You can give it. Give it any time, but after adrenaline. Okay, stop thinking about that. Okay. Now about the acute limb ischemia. You should ideally, what I teach you guys is in C you should check the pulses in all the peripheries. Okay? And by adopting that scheme, that protocol, you will not miss acute limb ischemia. Okay? When you find acute limb ischemia, I've seen many of the people, they ask if the patient is coming with a leg pain, we go straight to the leg or go to the, do the A to E. So my answer is A to E. Okay? A to E. When the patient has developed the pain in the leg or the clot in the leg, they can develop in the lungs as well. Okay? So do A to E. But in C you will find that there is a trouble. Okay? It is important that when you check the pulse, okay, you check the temperature and you check the sensations and you find the level of the obstruction as well. Okay. It will guide you which direction the patient will be going to and who is a specialist that you need to refer the patient. Okay. And what are the investigations you need to do? Okay. What is the investigation, Nava?
We have to do heart racing.
Doppler
Doppler, yeah.
Tell me one specific.
D-dimer.
D-dimer. Because the
For
results was not
pulmonary involvement,
Limb ischemia.
Scan.
Scan.
What's the question?
Thousands of scans. I need the name. What is the name of the scan?
Trying to break your injection.
For the acute limb ischemia.
Doppler ultrasound and CT angiogram.
CT angiogram. CT angiogram. Okay. No one pays even 5 minutes attention to the notes, but if you do not have access, I get the messages in the middle of night. Dr. Rashid, we cannot access those. Okay. Honestly, none of the people who have the access, they go and read anything. Okay. But I can get the messages when I'm working, when I'm driving, when I'm sleeping. I can get the messages. Okay. So, CT angiogram. However, who needs it? For which patient you will do the CT angiogram and for which you will not?
pulmonary embolism.
No, we are still talking about the acute limb ischemia.
If the D-dimer is...
I'm not going to do the D-dimer. I'm not worried about that. Okay. That is not the gold standard investigation of this. Okay. Just tell me for which patient you will do the CT angiogram and for which you will not.
We'll check for the well score. I think it's more than 4, then we'll go for it.
For,
No.
for pregnant women, we cannot do the CT.
If it is a male. Okay, now
Pulses.
as a male patient, for which male patient with acute limb ischemia you will not do the CT angiogram?
We have
Kidney
kidney
dysfunction.
Okay.
or they have
Is it
allergic
some sort
to
of sensitivity?
contrast.
Huh?
Sensitivity to the
If patient has AF,
contrast.
that would give me a clue of doing CT.
Okay. Now, which patient? Okay, so say for example, now this is a male with AF with acute limb ischemia. Okay, who will get the CT angiogram and who will not?
The pulses, if it is not the femoral pulse.
Okay, now it's a time critical. Okay, the patient who does not have the sensation, the power, okay, they are not the candidates for the CT angiogram. If they have the sensations and the power, this is why I said you to check the
Sensitivity of the patient.
not the sensitivity. Sensitivity is different from the sensations. Okay, so if the patient has a sensation and the power, then you can do the CT angiogram. Otherwise, by the time you will get the CT angiogram, the patient will develop further extension and may die. Okay, so we do not do the CT angiogram. Okay, because we know that the sensations are gone, power is gone, the patient's leg is already dead, it needs amputation. Okay, we do the CT angiogram in case where we see that yes, this is a salvageable limb. The limb can be saved. Does it make sense?
So what about the Doppler?
Doppler is a standard investigation that you do in the A&E. Okay, the people are walking like this. Okay, with the Doppler scan.
Do we have to do the Doppler or the CT?
Doppler is not the investigation. Okay. So CT is a standard gold standard
So what
investigation.
we call CTPA is
CT angiogram.
CT angiogram.
Yeah, it is a CT angiogram. Okay. CTP is a pulmonary angiogram. Okay. This is a CT angiogram. Okay.
So what are we inferring from the pulses? If the pulses are not present, then it means that.
Sorry.
There is an embolism.
So it can be thrombus or the embolism. Okay. So it is. We do the CT angiogram to find out exactly about the level. Okay. And to find out where the obstruction is and what is the segment, whether this is a small segment, short segment, that's a stent. Okay. If it's a long segment, that's a bypass, isn't it? You cannot put a stent here, but you can do for this. Okay. If it's a short segment, then the patient will need referral to the interventional radiologist and vascular surgeons. But if you see that there is no pulse, no sensation, no power, everything, the limb is dead, refer the patient to the orthopedist. Okay. If you call the vascular surgeon, they'll say, what do you want me to do? Okay, I'm not here to chop the limb. Okay, ask them. Okay, yes, if you have a vessel for me to save, I'll put the stent or do the bypass and happy. Okay, I don't deal with the bones.
So interventional radiologist or the vascular surgeon in case
Refer to both of them. Okay, refer to both of them.
So what is the difference in the sensitivity we're talking about? We said that we will check the sensitivity as well.
Not the sensitivity. Sensitivity is sensation.
Sensation.
Sensations. Okay. Can the patient feel you? Okay, or not? Okay. So ask them, can you feel me touch here? If the sensations are gone, then the next thing that will go in the patient is the power. Okay. If the patient has the sensations, another thing is, if the patient can feel you touch here, then you are not worried about the power. Okay. So the sequence of events in the acute limb ischemia is the first thing that goes is a pulse, second is the sensation, third is the power. Okay. If you cannot feel the pulse now, this is again very important for you, that there should be no pulse, palpable pulse, but the patient should have the pulse on the Doppler. Okay. Okay.
So we do bedside Doppler.
Yeah. So no palpable pulse, but the pulse present on Doppler. Okay.
How would we confirm that?
With the Doppler. Okay. There are people roaming around to do the Doppler. There is no problem. Okay. You can do the Doppler. They will teach you. Okay. It is just as if nurses are doing the urinalysis. It's so common. Okay. It's so easy as well after a bit of time.
No, I'm saying if, for example, in the exam we are not able to find the pulse, do we have to say I'll use the Doppler to find the pulse, or do we have to go to the power like that?
No, you simply mention, ask the patient, can you feel? Okay, do not worry about the Doppler, but you can mention this to the patient or to the examiner if you ask that ideally I will do the Doppler as well. I cannot feel the pulse because that's the next thing that we need to do. Okay.
So if there is no pulse, but there is sensation, so that means I am not able to feel it. It is there, right?
Yeah, on the Doppler, if there is a pulse.
No, I'm saying you said first the sensation will go, then pulse, then power.
No, I said first pulse, then sensation, then power. Pulse, sensation, and power. Okay. So there is a Rutherford classification of the acute limb ischemia. On your notes, you can go and access it. Okay.
Can you show us the touch and sensation, how to check it?
Yeah, no, you checking the pulse, isn't it?
Pulse is there.
Yeah, you checking. Ask the patient at the same time, can you feel me touching here? Okay.
And power?
Power, you can ask them, no, this is a bit difficult situation, okay? The patient, the simulator cannot, the simman cannot lift their leg up, okay? You can ask them, are you able to wiggle your toes? Or, okay? Or do you feel any weakness in your limb? You can ask them. But do not expect the simman to start lifting or bouncing the legs, okay?
So we have to start from the pulse from the distal end to the pulse.
Yes. Okay. So if there is a distal pulse, then likely there is a problem. Okay. So then we are not much worried. That's why I said in C you should always check the pulse in C, all the peripheral pulses. Okay. Does it make sense? All right. Any question before we jump forward for the scenarios?
So just for the motor, you said that we will ask that do you experience any weakness?
Mm-hmm.
And you mentioned one more question. I could not get your toes.
Wiggle the toes, wiggle the toes. Wiggle the toes. Okay? Wiggle the toes.
Doctor, other than CT angiogram, what can we do? Like investigations?
CT angiogram and?
Yes. And what else can we do?
Okay, so in terms of the management, okay, the whole management for this is for the acute limb ischemia, but don't worry, I will try to put it tonight on your course, okay, so that you can go and see that. First of all, nail bed mouth, okay, that's you need to make sure. Anyway, this patient is going to require. The first thing for, in terms of the treatment, okay, IV heparin infusion. Okay, so you need to give them in bolus and infusion. Okay, so 5,000 units IV stat. It is important. It's intravenous. Okay, I've seen the candidates fail after giving low molecular weight heparin. Okay, or unfractioned heparin subcutaneously. It has to be unfractioned heparin intravenously. Okay, 5,000 units stat and 20,000 units over the next 16 hours. It's all written. It's all written.
Oh, sorry, in your notes you put 30,000. I know when you taught us, you said 20.
So it's a 20 to 30. Okay. It is based on the. It varies from trust to trust. Okay. So you can go for anything.
Okay.
Anything?
Okay, but this same patient, the one I did before, here, he was complaining of pain. So we start with morphine first before. You know, you told me you were the one that submitted.
Yeah. Okay.
So you give an analgesic first before the heparin, or heparin first before analgesic.
Oh, give them analgesic.
Okay.
Yeah. If the patient is yelling, crying with the pain, just give that. Okay. Give that, because otherwise you may not be able to assess the patient. Okay. You need to assess the patient. Okay? You need to assess the patient. If the patient gets more comfortable, the sooner the better. Okay. Now, did you want to ask anything?
Yeah. In postpartum hemorrhage, what is the management in postpartum?
We'll stick to this scenario first, okay? Then we'll talk about it. We'll talk about the management as we go along. Okay, so we're talking about the approaches and what are the things that you need to look for. Now, those patients may need the theta, you know that likely, and you are going to start the patient with heparin as well. Okay, patients are likely going to bleed a lot. So think ahead before that happens. Blood group, cross match, okay, and arrange 2 units or 4 units of blood and stuff like that. Okay? All those things are important. Keep the patient nil by month.
Okay, in acute limb ischemia, when we are giving analgesic, we are giving paracetamol.
I will check allergy. Okay. I will check allergy of the patient. If the patient is allergic to any medication, I will not give, even if it is paracetamol. There is no standard rule. Okay. It varies from person to person. Okay. I've seen the patients just last week. She got 5 stitches without any local anesthetic. Okay. I've seen the patient who wanted local anesthetic even for 1 stitch. It varies from person to person. How bad the pain is. Okay. Whether the patient has a good threshold, the bad threshold, deal according to that. I do not want to create the robots, to be honest. Okay. It's very easy for me to just come and talk, and tell you, say this, and go away. Okay. Just learn and change yourself according to the situations. If the patient is crying the pain, it means the pain is severe. Right? You can give the patient anything for the pain. What they want to see is a sympathy. You are not actually giving anything. Okay? Whether you show the sympathy or not. Okay? If you leave the patient crying of the pain, it means that you are very cruel, very harsh with the patient. Okay, you're not considering any sympathy, empathy. Okay. So what I want to listen from you is that you consider their pain, that they are in pain. You empathize them. You show some sympathy. Okay. I don't bother whatever you give.
But along with sympathy, empathy, we have to remember that we have to follow the pain letter.
No.
No?
So what will you do for the patient who is allergic to paracetamol? Okay. Where is the pain letter? Where is the pain letter? Okay. So that is not the letter where you go from bottom to top. Okay. It is just how to wean off or how to optimize. If one is not working, how to go to the next one. Okay. But you can start from anywhere. If the patient is already sitting on the top and he has to come down, okay, and you're going to start the reverse gear, okay. And the patient, say for example, severe pain, okay, the pain is already at max. You use the top end, you can use it, okay. The pain is already in the highest one, you can use it, okay. Control the pain. If the morphine is not working, then you may need to consider something else, like after the operation surgeries. Okay, what we do is we simply start the stronger painkiller and come down slowly, wean out slowly, because we know that the patient will have pain for some time. The pain will settle slowly, then we start from the top. Okay, do not worry about that.
But generally, paracetamol has got less side effect than morphine. So that's how we should think about paracetamol first.
I think you are very rigid about those things. Okay, just consider the patient.
Okay.
What are the side effects that you will see with morphine? Nausea, vomiting. Okay, so but if the patient is allergic to paracetamol.
No, if the patient is allergic, we are not giving that.
Okay.
Then
See what is said. You from your examination point of you are mixing the situations. Either you consider the examination point of view. From the examination point of view, what I want to see is that you show the sympathy. Okay, even if you give anything, but not something which the patient is allergic to, the patient will improve. Okay, it is not the paracetamol, it's not the NSAIDs or anything. Okay, you just need to show that the patient was crying and you said, okay, I will give you something to control the pain. Are you allergic to something? The patient says ibuprofen. You said, okay, I will give you morphine. You will get the same marks if she says, I will give you diclofenac. Okay, same marks. He says paracetamol, same marks. Okay, what you are showing is a sympathy. Okay, it's not the pain. It is not the assessment of what painkiller you're choosing. Okay, we are considering the sympathy and the safety.
Isn't it whenever there is stoppage in the blood flow, be it in case of ischemia or in case of MI, the pain is so severe that you just have to go for morphine, right?
Yeah, this is what I'm saying. Yeah, when the pain is severe, you start with the stronger painkiller. Okay.
The pain is unbearable.
Yeah, if the pain is, again, however, again, if the patient says, doctor, I can tolerate. Okay, you don't give any painkiller. I've seen a patient with the subarachnoid hemorrhage. Okay, she tolerated. Okay, but she collapsed and she needed intubation and everything. And she didn't need. She denied the painkiller. She said, no, I'm okay. So it varies from patient to patient. Okay, the things that we are looking for as an examiner, sympathy and safety. Okay, it is not the judgment of whether you follow the pain letter or not. Okay, any questions, guys?
So in acute ischemia, you talked about that we will be arranging for blood grouping and all these things. Because patient might, obviously he might need a surgery, so he may bleed. Is this the reason?
Yes. Okay. Okay, now let's take a few minutes break, then we will do the practice, okay? And the practice will be you will see the scenario, read the scenario there, okay, on the screen, on the monitor, and perform here. Okay? And you will come in turns.
So for how long do you have a break?
10 minutes, 15 minutes. Tell me quickly, how much? Riyam, Ruqayya, Sadaf, how long? 15, 10?
Yes,
Yes,
Dr.
6 minutes
Shah.
is fine.
Okay. So we stay like logged in? We
Sorry?
stay here or we leave?
You can join in 5-10 minutes. It's your, but the meeting is going on. Okay?
Sorry, was that? Say that again.
So we will be back in 10 minutes. Okay.
Okay, shall we leave or just stay mute?
That's your choice. You don't need to leave if you don't want to. You can make your cup of tea.
Okay.
Okay.
Yeah. Yeah. Okay.